Today, our topic is clinical evaluation and imaging of posterior segment in glaucoma. First, we are just telling about little about optic nerve anatomy, so that we can understand the normal and pathological appearance of the optic nerve. That how that allows to detect and monitor glaucoma. The optic nerve is composed of the axons of retinal ganglion cells, glial tissue, extracellular matrix, and blood vessels, and it consists of approximately 1.5 to 1.2 to 1.5 retinal ganglion cells, axons. And cell bodies of retinal ganglion cells lies in the ganglion cell layer of retina, and their axon synapses at the lateral genicular nucleus. And the intraorbital portion of the optic nerve has two components: anterior optic nerve and posterior optic nerve. And the anterior optic nerve extends from the retinal surface to the retrolaminar region, where the nerve exits the posterior aspect of the globe. And the average diameter of the optic nerve head, ONH, is 1.5 to 1.7 millimeter. And they immediately exit the globe. The optic nerve expands to approximately 3 to 4 millimeter. This increase in size is due to axonal myelination, glial tissue, and the beginning of the leptomeninges, that is the optic nerve sheath. The axons are separated into fascicles within the optic nerve with the intervening spaces occupied by the astrocytes. Next, the distribution of nerve fibers as they enter into the optic nerve head. In this picture, we can see the arcuate nerve fibers entering the superior and inferior pole of the optic nerve are more susceptible to the glaucomatous damage. This is because the large size of the pores of the lamina cribrosa in these regions. This susceptibility explains the frequent occurrence of arcuate visual field defects in eyes with glaucoma, and the arrangement of the axons in the optic nerve head and their differential susceptibility to damage determine the patterns of the visual field loss in glaucoma. Here in this picture, we can see peripheral fibers. These peripheral fibers are run closer to the choroid and exit in the periphery of the optic nerve, where the fibers originating closer to the nerve head are situated closer to the vitreous and occupy more central portion of the nerve. Here the fovea is depicted as being located along the horizontal meridian through the center of the optic disc. But in most eyes, it's fovea is located inferior to the horizontal meridian. The anterior optic nerve can be divided into four layers, that is nerve fiber layer, prelaminar layer, laminar layer, and retrolaminar. The most anterior zone is superficial nerve fiber layer, and which continues with the nerve fiber layer of the retina, and the region is composed primarily with the axons of retinal ganglion cells, that is a transition from superficial retina to neuronal component of the optic nerve. The nerve fiber layer can be best visualized with a slit lamp biomicroscopy or fundus photographs with a red free filter, that is green color, and posterior to the nerve fiber layer is the prelaminar region, and it's adjacent to the peripapillary choroid. And the most posteriorly laminar region is continuous with the sclera and is composed of lamina cribrosa, and this is a structure consisting of fenestrated connective tissue lamellae that allow the transit of neural fibers to the scleral cord. Next, the retrolaminar region, posterior to lamina cribrosa, is marked by the beginning of the axonal myelination and is surrounded by the leptomeninges of the CNS. First, next, lamina cribrosa, it provides the main structural support of the optic nerve as it exits the eye, and it consists of a reticulated network of connective tissue beam that are composed of collagen primarily, then extracellular matrix substance such as laminin and fibronectin is also there, and laminar beams also contain capillaries that nourish this critical region. And the neural components of the optic nerve pass through these connective tissue beams, and in addition, relatively large central fenestrations are there which allow the passage of central retinal artery and retinal vein through the lamina cribrosa. And the scanning electron microscopy of the normal lamina cribrosa shows a lower density of connective tissue and extracellular matrix material at its inferior and superior poles, where the laminar poles are larger in comparison to nasal and temporal regions in these superior and inferior poles. So this difference also explains greater susceptibility to damage of the inferior and superior regions of the optic nerve. The pores of the lamina cribrosa may often seen by ophthalmoscopy at the base of the optic disc cup. Between the optic nerve and the adjacent choroid and scleral tissue lies a rim of connective tissue called the ring of Aisling. Here the picture showing the imaging of lamina cribrosa. We can see which shows a reticulated network of connective tissue beam. This picture is an anterior view of human lamina cribrosa from a healthy donor. Here we can see reticular network of supporting connective tissue. This is electron micrograph of a non-glaucomatous lamina cribrosa. Here the arrow points to central retinal vessels. S means superior and temporal. T is temporal regions of lamina cribrosa. Density of connective tissue and the size of the laminar pores vary by region. Laminar cribrosa is thought to be more structurally vulnerable to damage in the inferior and superior poles of optic nerve head because we can see the larger pores in these locations almost compared to this temporal and nasal regions. Here you can see somewhat larger. Blood supply to the optic nerve. Arterial supply of the anterior optic nerve is derived entirely from branches of ophthalmic artery via 1 to 5 posterior ciliary arteries. And typically between 2 and 4 posterior ciliary artery courses, they course anteriorly before dividing into 10 to 20 short posterior ciliary arteries prior to entering the posterior globe. The posterior ciliary arteries separate into medial and lateral group before branching into short posterior ciliary arteries. These arteries penetrate the perineural sclera of the posterior globe to supply peripapillary choroida and most of the anterior optic nerve. The central retinal artery and the posterior orbital branch of the ophthalmic artery penetrates the optic nerve and the central retinal artery they will anastomose with the pile system also, and the central retinal artery cords adjacent to the central retinal vein within the central portion of the optic nerve. And the superficial nerve fiber layer is getting blood supply from recurrent retinal arteries branching from the central retinal artery, and some small vessels known as epipapillary vessels originating in peripapillary nerve fiber layer and run toward the center of the optic nerve head. The temporal nerve fiber layer, they are getting blood from the filioretinal artery. The prelaminar region, it's supplied by the direct branches of the short posterior ciliary arteries and branches from the circle of Sinhala. And in some person, the eyes with the well-developed this circle, that is circle of Sinhala, that is a discontinuous arterial circle exit within the perineural sclera, and these branches from these circle of Sinhala emerge to supply both the prelaminar and laminar regions. And similar to prelaminar region, lamina cribrosa region receives its blood supply from the branches of again short posterior ciliary arteries and the branches from the circle of Sinhala. And this is the anterior optic nerve vasculature. A is this part showing the artery supply to the anterior optic nerve and the peripapillary choroida. And this picture showing the venous drainage of anterior optic nerve. The retrolaminar region is also supplied by the branches from the short posterior ciliary arteries and the pial artery branches also. Next, venous drainage of the anterior optic nerve is by a single vein, that is central retinal vein. And in nerve fiber layer, blood drains directly into the retinal veins, which then join to form central retinal vein. The prelaminar, laminar and retrolaminar regions, venous drainage is also occurs via central retinal vein or axial tributaries to the central retinal vein. Next, glaucomatous optic neuropathy. So characteristic changes in the optic.
Shilpa,
Sir.
that blood supply to the limbus,
Sir.
blood supply to
Sir.
that's what you have to, the diagram, you have to
Sir.
practice.
Sir.
Yeah, it's a short question. The diagram you have to practice physically.
Sir.
Yeah, you put it the diagram here, but you have to draw it actually.
Sir.
That's a, for exam point of view, it's very important.
Sir.
From where, Shilpa, this was? This image
Sir,
is from where?
this picture is from AAO's journal, sir.
Journal, huh? Okay, anatomy,
glaucoma journal.
anatomy book, you have a diagrammatic representation.
Sir.
What sir is asking. You
sir.
have to draw. And thus RNFL arrangement also you mentioned, no, in the first one or two slides.
Sir.
That also you have to practice.
Sir.
And
okay, sir.
you
For,
didn't mention about the regions of nerve fiber. So first you have to draw the maculopapular bundle.
Sir, this image.
Then
In this.
then first maculopapular bundle,
Sir.
temporal to the disc.
Sir.
Then it is the inferior and the superior arcuate fibers.
Sir.
And then nasal fibers.
Sir.
So this diagram is also important, and that let's apply to the optic nerve head is also important. You have to practice things.
Sir.
And the inferior, there is a small square which is showing peripheral fibers will be
more close to the
superficial. They are more superficial. Peripheral fibers are more superficial in the optic nerve, and central nerve fibers will be in the deeper part of the optic. Okay. Yeah.
So this diagram represents the optical changes what we are mentioning, no? Inferior, nasal, endoscopy, all these things. All these things are depending on this diagram only. Later on, glaucoma specific field defects, all according to this diagram only.
Yes. According to RNFL arrangements in posterior.
Sir, glaucomatous, sir, shall I continue, sir?
Yeah, continue.
Glaucomatous optic neuropathy. Characteristic changes in optic nerve head are defining feature of the glaucoma. And histological examination reveals that early glaucomatous cupping begins with structural damage to the lamina cribrosa. Subsequently, there is apoptotic loss of retinal ganglion cells and their axon, blood vessels, and glial cells. The retinal ganglion cell axonal damage begins at the level of lamina cribrosa. It is most pronounced at the superior and inferior pole of optic nerve head. In many cases, it's not always, structural optic nerve damage may precede detectable functional loss as measured by standard perimetry. Glaucomatous optic neuropathy is a progressive degeneration of retinal ganglion cells and their axons in association with the lamina cribrosa damage characterized by rupture of laminar beams and enlargement of the optic disc cup. And transsynaptic neurodegeneration extends from the optic nerve to the major vision centers in brainstem such as lateral geniculate nucleus and the occipital cortex. Intraocular pressure plays a major role in the development of glaucomatous optic neuropathy. Is most affected individuals and is considered the most significant risk factor. And IOP can cause mechanical stress and strain on the posterior structures of the eye, particularly lamina cribrosa, which is the weakest point in the posterior wall of the eye and its adjacent tissues. Now, IOP-induced stress and strain may result in compression, deformation, and remodeling of the lamina cribrosa, and which causes mechanical axonal damage and disruption of the axonal transport. And studies involving in animals like cats and monkeys with the experimentally induced ocular hypertension, they have showed blockade of the both retrograde and anterograde axonal transport at the level of lamina cribrosa. And this blockage of axonal transport occurs early in the pathogenesis of glaucoma, and that interrupts the retrograde delivery of essential tropic factors to retinal ganglion cells from the brainstem, and And these factors are relying in the neurons of the lateral genicular nucleus, and the transport is cut off. And disrupted axonal transport also results in collections of vesicles and disorganization of microtubules and neurofilaments in the prelaminar and postlaminar regions. Impaired microcirculation, altered immunity, excitotoxicity, and oxidative stress may also contribute to the pathogenesis of glaucomatous damage. And current thinking recognize that glaucoma comprises a heterogeneous family of disorders mediated most likely by many factors. And this is a views of glaucomatous optic nerve, and diagram A shows glaucomatous optic nerve and it's in a transverse view of right eye, and we can see the thinning, undermining, and the focal notching here. Focal notching of the inferior neuroretinal rim, and enlarged central cup with the visible laminar fenestrations. We can see this, and nasal shifting of retinal vessels, nasalized retinal vessels, and peripapillary atrophy also we can see. And this is a clinical view of optic nerve head demonstrating extensive loss of neuroretinal rim in this picture. Next, clinical examination of the optic nerve head. Clinical examination of optic nerve head is performed with a slit lamp biomicroscope. Can be combined with a high magnification posterior pole lens like 60D, 78 or 90D lens. The slit beam, rather than diffuse illumination, it's useful for the determining the subtle changes in the contour of the optic nerve head. This system provides high magnification, excellent illumination, and a stereoscopic view. In addition, adjusting the height of the slit beam enables quantitative measurement of the diameter of the optic nerve. The disc is viewed through the handheld lens, and the height of the slit beam is adjusted so that it is the same as vertical diameter of the disc. And the disc diameter can be calculated adjusting for the magnification of the lens used as follows like that. With the 60D lens, the height of the slit equals to the disc diameter in millimeters, and we can read it directly from the scale. And but in case of 78D, we have to multiply the height of the slit by 1.1, and with the 90D lens, we have to multiply with 1.3. The normal optic nerve head ranges from 1.5 to 2.2 millimeter in diameter, and patient's refractive error will affect this measurement. And in patient with myopia, underestimation, and in patient with hyperopia, overestimation can be occur. And the direct ophthalmoscope may also be used for the clinical examination of optic nerve head, but this instrument may not provide sufficient stereoscopic detail to detect the subtle changes in optic head topography. And the indirect ophthalmoscope can be used for the examination in young children and patients who are unable to cooperate with the slit lamp biomicroscopy. Then lower power lenses, then 15D, can also be helpful when slit lamp biomicroscopy is not possible and more detailed view of optic nerve is needed. With the indirect ophthalmoscope, optic nerve cupping pallor appear less pronounced than the slit lamp method, and the magnification offered by the indirect is often inadequate for detecting subtle or localized details important for the evaluation of glaucoma. So the indirect ophthalmoscopy is not recommended for the routine examination for the optic nerve head in glaucoma. And the ONH is usually round or slightly oval in shape and contains a central cup. The tissue between the cup and the disc margin is called neuroretinal rim or neural rim. The size of the physiologic cup is developmentally determined and is related to the size of the disc. For a given number of nerve fibers, the larger the overall disc area is, the larger the cup will be. The cup disc ratio alone is not an adequate measurement of optic nerve head for possible glaucomatous damage. And for example, a 0.7 cup disc ratio in a large optic nerve head may be normal, whereas 0.3 cup disc ratio in a very small disc is likely pathologic. This assessment of the disc size is important. In healthy subjects, a small cup, that's vertical disc diameter less than 1.5 millimeter, will have a small cup, whereas a large disc, vertical disc diameter greater than 2.2 millimeter will have a larger cup. Individuals of African ancestry on an average have a larger disc area and larger cup disc ratio than the white individuals.
So this is a very, very important for topic, Shilpa and Sonika.
Sure.
So you should not only determine on the cup, how much
Sure.
the cup is.
Sure.
It should be proportional to the disc size.
Sure.
So if it is proportional to the disc size, maybe it might be a physiological. So how to measure disc size also you mentioned, right?
Sure.
With the 90D with a vertical slit.
Sure.
How much will be and multiplied by 1.3. So actually you can compare the size in both the eyes.
Yeah.
Not only particularly in this symmetrical size is important.
Sure.
The asymmetry of the cup, whenever you see the asymmetry of the cup in both the eyes, you have to see the symmetrical disc size.
Sure.
Is there any asymmetry in the disc size also?
Sure.
So if it is there, it might be physiological.
Sure.
That is more important.
Sure.
Yeah. Continue.
So when you're doing 90D examination,
Sure.
you should concentrate on disc for some time, okay?
Sure.
You have to, maybe for a minute, you have to concentrate on disc.
Sure.
Go ahead.
Yeah.
Go ahead.
Go ahead.
The early changes of glaucomatous optic neuropathy are subtle and include these following, like generalized enlargement of the cup, focal rim thinning, superficial disc hemorrhage, and retinal nerve fiber layer atrophy, asymmetry of the cupping, and peripapillary atrophy of the beta zone. And diffuse neuroretinal rim thinning associated with the generalized enlargement of the cup may be an early sign, and however, diffuse loss may be difficult to appreciate unless previous objective documentation of the optic nerve head, like photographs available. But comparing one eye with the fellow eye may be helpful because cup disc ratio asymmetry greater than 0.2 is unusual in healthy eyes in the absence of disc size asymmetry. And the vertical cup disc ratio typically ranges between 0.1 and 0.4. Although up to 5% of individuals with glaucoma will have cup disc ratio larger than 0.6. Asymmetry of the cup disc ratio of more than 0.2 occurs in fewer than 1% of individuals without glaucoma. So this may be related to disc size asymmetry. And increased size of the physiological cup may be familiar trait, and it is also observed with the high myopia. Ophthalmoscopic signs of glaucoma and generalized signs like larger optic cup, asymmetry of the cup between two eyes, and progressive enlargement of the cup. Focal changes like a notching of the rim, vertical elongation of the cup, cupping to the rim margin, nerve fiber layer hemorrhage, nerve fiber layer loss, and less specific things like exposure to lamina cribrosa, nasal displacement of the vessels, and bearing of circumlinear vessels, and peripapillary atrophy. An oblique insertion of the optic nerve into the globe of individuals with high myopia may also cause optic nerve to appear tilted, and examination of other family members may clarify whether a large cup is inherited or acquired. Localized loss of the neuroretinal rim usually occurs first at the inferior and superior temporal poles of the optic nerve in early glaucomatous optic neuropathy. And this picture shows generalized in picture A, generalized enlargement of the cup in the right eye, and in picture B, it's a normal eye. We can compare like this right eye and normal left eye. Here, enlargement of the cup we see. And progressive. This is a progressive optic disc excavation in a patient with the uncontrolled open angle glaucoma over 3-year period. The overall size of the optic disc is small here. In picture A, the inferior overall cup size is larger than the expected for a small cup disc, and the inferior ureteral rim is thinning here, thinner than the superior rim, and shows the early glaucomatous optic neuropathy. And picture B, there is a progressive thinning of the here thinning. We can see inferior ureteral rim at 5 o'clock position, and optic disc hemorrhage is present at the same location. Here we can see optic disc hemorrhage, and in picture C, the further inferior 5 o'clock position rim loss, and here is a notch is developing here. And this is optical photograph showing vertical elongation
The
of
previous slide.
sir.
Previous slide.
Sir.
In the last C image, you can see the RNFL defect also. Corresponding RNFL defect.
Sir, this
Whatever you have mentioned in this disc hemorrhage in the B photograph,
sir.
there is a continuation of that retinal nerve
Sir.
fiber layer defect. There is a dark gray band along
Sir.
in the C there, yes, in the C image picture of the picture C, it is very much evident that there is a shaped RNFLD along with the disc margin.
Sir. Thank you, sir.
Okay.
And this picture, optical photograph showing vertical elongation of the cup with the localized thinning of the inferior and superior neuroretinal limb of the left eye of a patient with the moderately advanced glaucoma. In this picture, acquired optic disc picture. Here it's located in the infero or temporal region. Here rim tissue is absent here, almost absent. And the preferential loss of rim tissue in the superior inferior poles leads to vertically elongated cupping glaucomatous nerve. To help identify subtle thinning of the neuroretinal limb, the Eason rule may be useful. In healthy eyes, the Eason rule is, in healthy eyes, the inferior neuroretinal rim is generally the thickest, followed by the superior rim and then the nasal rim, and finally the temporal rim. So the temporal rim is the thinnest in healthy eyes. So if the rim width do not follow this pattern, there should be increased concern for focal loss of rim tissue. The violation of the Eason rule is not highly specific and may also observed in healthy eyes also. In this picture, we can see like this localized thinning and deep localized notching in with the lamina cribrosa is visible at disc margin is sometimes termed as acquired optic disc pitch. Patients with acquired pitch are at especially high risk for progression of glaucoma. Here we can see acquired optic disc pitch in the inferotemporal. Even in a healthy eye, laminar trabulations or pores may be visible as grayish dots in the base of the physiological cup, and in glaucomatous optic neuropathy, optic disc excavation is characterized by extensive exposure of the underlying lamina cribrosa and its pores or striations in the optic nerve cup. In this picture, we can see striations of lamina cribrosa in optic nerve with severe glaucomatous damage. In the backward moving strain and compression of the lamina cribrosa cause damage to the laminar pores and beams. The glaucomatous damage to lamina cribrosa also cause tearing of the connective tissue bundles between the pores, leading to quiescence of the small pores and forming the big larger pores. And the cup enlarges. The nasal migration of the central retinal artery and retinal vein is also observed. And retinal nerve fiber layer hemorrhages. It can be a sign of glaucoma and appear as a linear red streak or on or near to the disc surface, and the appearance can be highly variable. Here we can see flame-shaped optic disc hemorrhage in left optic nerve head in 5 o'clock position. Hemorrhages may be difficult to detect unless the clinician actively searching for them, and at some time during the course of the diseases, 1/3 of the patient with the glaucoma may develop hemorrhages, and it can be there for several weeks to few months. And disc hemorrhages are an important prognostic sign for the development or progression of visual field loss. In many cases, the disc hemorrhages are followed by localized notching of the rim and visual field loss. We saw this picture previously. Sir explained that here one hemorrhage and rim notching is developing later. Disc hemorrhages may also be caused by posterior vitreous detachment, diabetes mellitus, retinal vein occlusions, and anticoagulation therapy. So it's not that much specific for glaucoma. The retinal nerve fiber layer of a healthy eye is the best visualized with the red-green illumination, as the nerve fibers extend from the peripheral retina to converge at the optic nerve head. They appear as a fine striations created by the bundle of axons. In healthy eye, the brightness and the striations of the nerve fiber layer are more easily visible superiorly and inferiorly. In eye with the progressive glaucomatous optic neuropathy, the NLF thins and become less visible. This brightness and striations are less visible. So the loss may be diffuse or localized. With the diffuse loss, there is a general decrease in retinal nerve fiber layer brightness with a reduction of the usual difference between superior and inferior poles in comparison to the temporal and nasal regions. Localized retinal nerve fiber layer loss, it appears as a bud-shaped dark areas emanating from the ONH in arcuate pattern, as we previously showed in one picture. Diffuse nerve fiber loss is more common in glaucoma than focal loss, but it's also more difficult to observe. Here we can see in this picture, nerve fiber photograph shows a nerve fiber bundle defect. This one. And
in between the black arrows.
Sir.
No, the defect is in between the black arrows. And it should correlate to the notching.
Sir.
No, notching of the rim, notching or thinning at the particular rim. So it should correlate. RNFL defects may also be seen physiologically.
Sure.
No, they may not continue. They will not continue with the disc margin.
Sure.
And it will be correlated with the rim loss.
Okay, sir.
There can be visual RNFLD, which is a physiological also. Physiological also. Okay.
Sir, visual field effect will be there, sir, in that case. Physiological.
Mostly it won't be there. The only thing is it should correlate with the rim loss and continue with the disc margin.
Disc margin.
It's a small tip over 60 parts. Is observing RNL defect is a highly subjective intervariability is there. There is a small tip to you. Red free light is important. And usually, if you stick a cellophane tape, lasering tape, if there is observe it like that. If there is a defect in the tape, you can identify that, no? So if there is a RNF defect is there, that you can observe that like a cellophane, there is a defect. With RNF, it's a glistening tape, tape-like. It's just a tip, practical tip, because many times this glaucoma specialist say it's RNF defect, and we will not find out. Yeah, that is just like that. Cellophane tape is like that, just for a small practical tip.
And one more thing is you have to see a dilated fundus to pick up an RNFL defect. So undilated you may miss. If you like in your practice also, I'm telling, not in initial days. Undilated also we can see disc cupping, thinning of rim, everything. But to see the RNFL defect, it should be relative to the normal retina. So we have to see the normal retina also properly in a dilated fundus, so that you will appreciate the retinal nerve fibrillary defect, which is dark gray. So sometimes a light gray thing we can miss in the undilated fundus. That too, red flip filter will highlight that. So looking for RNFLD in a red-free filter is it should be practiced. It should be practiced.
Sure.
Even in a slit lamp also.
Sure.
And for that only, lot of there are some papers also, articles which say that RNFLD is missed by clinicians, but picked up by fundus photograph.
Sure.
So a lot of the times.
Sure.
Documentation is also very, very important. So
Sure.
fundus photo with red free filter is very much important to see the RNF effect.
Sure.
Yeah.
The RNFL can be visualized clearly in high contrast black and white photographs. With good quality photographs, experienced clinician can recognize in early disease. Such photographs are difficult to obtain and have been largely abandoned in clinical practice due to availability of imaging methods to quantify RNFL thickness. And slit lamp techniques and direct ophthalmoscopy can be successfully employed to observe the RNFL. The combination of a red-free filter, a wide slit beam, posterior pole lens at the slit lamp gives the best view. The next is peripapillary atrophy. It's classified into two general types, alpha zone and beta zone. Alpha zone is present in most non-glaucomatous eye as well as in eyes with glaucoma and is characterized by a region of irregular hypo and hyperpigmentation of the retinal pigment epithelium. And it's more important, the more important type of peripapillary atrophy with respect to glaucoma is beta zone, which results from atrophy of the retinal pigment epithelium and choriocapillaries and leading to increased visibility of the large chorioretinal vessels and sclera. In this picture, we can see this beta zone is noted by the black arrows and the alpha zone is white arrow. This mark here in this beta zone, we can see the marked atrophy of the RPE and the large choroidal vessels can be this easily visible here. And alpha zone is peripheral and is adjacent to the beta zone and is characterized by a region of hypo and hyperpigmentation. Beta zone is most common and more common and excessive in eyes with glaucoma than healthy eye. And there is PPA is spatially correlated with the areas of neuroretinal rim loss. And the atrophy is largest in the corresponding area of thinner neuroretinal rim. Therefore, the area of beta zone atrophy signals the need for search of glaucomatous loss in the adjacent neuroretinal rim. Other less specific signs of glaucomatous damage include a nasal displacement of the vessels, narrowing of the peripapillary retinal vessels, bearing of the circumlinear vessels, and with the advanced damage, the cup become pale and markedly excavated. The conditions associated with optic nerve changes that can be confounded with the glaucoma include congenital pits of the optic nerve head, coloboma, morning glory disc anomaly, arteritic anterior ischemic neuropathy, and compressive optic neuropathies. And
Have you seen all these things?
No, sir.
Have you?
Coloboma I saw, sir, but not the disc coloboma.
You could have taken pictures, like you could have made a picture slides for these things.
Sir. Sir.
So that you will know what is these things, how to differentiate.
Sir.
You just search for it in the internet or in the textbooks.
Sir.
You just see these congenital pits of ONH, coloboma, morning glory. You have to see, then only you will know how to differentiate, all these things.
Sir.
Okay, and bionetting of vessels you didn't mention.
Sir.
Bearing of circumciliary vessels, you know what is that mean?
Sir.
So it's a three-dimensional viewing experience. Circumciliary vessels are not like a thick diameter. They are very less diameter vessels. They will be supported by the extracellular matrix in the lamina, like in the ONH. So whenever you have a deep cuppings or excavating cuppings, the loss of extracellular matrix in the lamina cribrosa will leave the vessel to travel over the ONH without any support.
Sir.
So it's a three-dimensional view. So that is circumlinear vessels will not follow the excavation. It will not follow the excavation of the cup. It just overflow the cup. It overbridges the cup. So that is varying of circumlinear vessels. And if you just go to the images which we have shown previously, that during that splinter hemorrhage or something, splinter hemorrhage you have shown, no? The central vein is there, no? Central vein, lateral to temporal to that one single vein is going on.
Sir, this one.
Temporally, right side to that. No, right side to that. That will be seen. That is the vein. That vessel we have to see in the slit lamp with a three-dimensional view. That will be bared out. It is not excavating. It's not following the counter of the cup.
Okay, sir.
And if you see inferiorly, the vessels are following the counter of the cup and they are bending at the disc margin. I can say cup margin.
Sir.
Inferiorly. Yes, there. So they are following the cupping, excavating cupping, and they are bending at the cup margin. Actually, here it is the disc margin because the rim is get lost at inferior margin. So that is bionetting.
Sir.
And superiorly it is bearing of circumlinear vessels. Okay.
Sir, optic hypertrophy or coloboma are possible causes of glaucomatis appearing visual field loss also. And myopic disc represents a challenge in the assessment of glaucomatis damage. Pallor to the neuroretinal rim itself is an indication of a non-glaucomatous optic neuropathy and it necessitates further investigation before diagnosing as glaucoma. And with rare exceptions, glaucoma results in increased cupping and pallor within the cup, but not the pallor of the remaining rim tissue. The rim pallor that is out of proportion to the degree of cupping may occur following previous episodes of IOP such as acute angular closure glaucoma episode.
That is very important, Shilpa.
Sir.
That line is very important.
Sir.
So simple pallor, more than cupping, you cannot go for a neurological disease.
Sir.
If we don't know also, there might be a acute high IOP.
Sir.
As you mentioned in acute angle closure, but usually at the episode of acute angle closure, it will be a hyperemic disc. In the sequel, if it is self-resolving or we have treated it in the acute phase,
Sir.
then the pallor may develop in the later stage.
Sir.
So when you see the acute angle closure, the disc will be hyperemic.
Right. Hyperemic.
But because of the high IOP, mechanical damage and mechanical pressure will cause a ischemia of the optic nerve. Then you can see the pallor in the later stages.
Sir.
As you see in the chronic angle closure, or it is a primarily it is an angle closure without any acute attack.
Sir.
But these things you can see in pseudoexfoliation and pigmentary glaucomas also, where we have mentioned previously that there will be a fluctuations in the IOP and there will be very high IOPs, especially in pseudoexfoliation glaucomas. They may present it with very high IOPs, more than 40 also. But the cornea will remain clear. Nothing. The patient will not be feeling anything symptomatic, but the pressures may be high. Sure. So these patients in the latter periods, they may have pallor.
Sure.
Okay, that is very, very important. Rim pallor that is out of proportion to the degree of cupping.
Sure.
But this doesn't eliminate glaucoma, and we cannot simply say that it is a neurological disease. That is why pallor is more than cupping.
Sure.
Yeah.
Next, recording of these findings. Due to the large variability in the appearance of the optic nerve head in healthy subject, it's not possible to confirm the presence of glaucomatous damage on the basis of single cross-sectional observation. So, glaucoma diagnosis frequently requires longitudinal. Frequently requires longitudinal monitoring and detection of the progressive damage over time. So careful documentation is essential in order to allow adequate comparison of the optic nerve head appearance over time, both for diagnosis of the disease and detection of progression in those with the established disease. It's common practice to grade on optic nerve head by comparing the diameter of the cup with the diameter of the disc, and the ratio is usually expressed as a decimal, for example 0.2, but such a description poorly conveys the appearance of the optic nerve head. So detailed annotated diagram of the optic nerve head topography is preferable for the recording. And then very detailed descriptions or drawing of the optic nerve head are generally insufficient to detect the subtle changes. So therefore an objective documentation, photograph or other imaging of the optic nerve head is needed. The stereo photography is an excellent method for recording the appearance of the optic nerve for detailed examination and follow-up. This allows the examiner to compare the present status of the patient with the baseline status without assorting to memory or grading system. Next, imaging of the optic nerve head, macula and the retinal nerve fiber layer. Since
Shilpa,
sir,
I just want to mention about EDLS. So, do you know about EDLS? Do you have disk damage likelihood score? DDLS. You just read about it. That is a documentation of cupping, like glaucomatous optic neuropathy.
Sir.
So the grading of optic neuropathy you are telling.
Sir.
That you just write and read about that. DDLS. Disk damage likelihood score.
Sir.
It is mentioned as the Krishna. Textbooks may not give that score.
I think it won't be there in textbooks. It will be there in articles, definitely. But glaucoma textbooks in recent editions, it might be there, sir.
Okay.
But in Shields 6th edition and Becker-Schaffer 6th edition, it was not mentioned. They are not re-editing it. They are fixed at that point of these things. So articles you will get, Shilpa and Sonika. So DDLS is much important for. Actually, it is an subjective thing, cupping, as sir mentioned. So if the DDLS is practiced, then it will be benefited to you.
Sir.
Okay.
Yeah, go through that and tell me also.
Sir, we'll post into sir after reading and writing. Post it.
Yeah. Okay.
Since the 1950s, the appearance of the optic nerve head has been recognized as a critical in assessing the glaucoma. So the assessment of the optic nerve with the slit lamp or with the photograph is subjective and shows relatively large intra-observer and intra-observer variation. So quantitative imaging device provide an objective means to obtain reproducible and high resolution images of ocular structures relevant to the glaucoma. So the imaging devices contain normative databases that allows the user to determine the probability that observed measurements are within the normal range or not. So imaging assessment is also helpful for detecting a progressive structural damage and the assessment of rate of disease progression. Advancements in ocular imaging technologies over the last 3 decades include OCT, confocal scanning laser ophthalmoscopy, that's CSLO, scanning laser polarimetry, that's SLP. The OCT is the most widely used nowadays because its versatility as well as its high resolution and reproducibility of the measurements. Now, OCT for glaucoma diagnosis. So, OCT employs the principles of log occurrence interferometry and analogous. It's analogous to ultrasound beam mode imaging, and it uses light instead of sound to acquire high resolution cross-sectional images of ocular structures. The original time domain OCT has been superseded by the spectral domain OCT. The SDOCT, that's a spectral domain OCT, has improved spatial resolution and image acquisition speed and resulting in enhanced image quality and better reproducibility. The OCT is able to provide quantity measurements of the peripapillary retinal nerve fiber layer thickness, optic nerve head topography, macular thickness, which can be discriminate glaucomatous eye from the healthy. And most commercially available OCT devices acquire RNFL thickness measurements in peripapillary circle located at a certain distance from the optic nerve head, usually 3.45 millimeter. And these RNFL thickness measurements are generally lower in glaucomatous eye compared with those with non-glaucomatous. And measurement parameters presented in OCT reports include the global average peripapillary retinal nerve fiber layer thickness, which corresponds to the average of all thickness measurements in peripapillary circle. The average retinal nerve fiber layer thickness in quadrants, that is superior, inferior, temporal, nasal, or in a small clock hour sectors. And this image shows an example of retinal nerve fiber layer analysis by SD-OCT. And in a patient with a glaucomatous retinal nerve fiber loss in right eye and normal RNFL in left eye. And this one, the top images, topmost portion shows the right eye shows the diffuse RNFL thinning on SD-OCT. Here compared to this normal left eye, we can see thinning is we can see, and also neuroretinal rim thinning and enlarged cup in this picture B, and visual corresponding visual field loss we can see in this C image. And this left eye shows a normal retinal nerve fiber layer thickness and normal appearance of optic nerve head and normal visual field.
This is from Kansky, huh?
Sir, no, sir. This is from the glaucoma article.
Okay.
So, Kansky is also having same images, sir. They
Yeah,
are taking
I
only
remember
images
this.
from,
Yeah,
sir.
I remember it is there in this.
Ah.
And if you see the right, which I'm not getting.
Sir?
Inferior part of the RNFL, which is normal.
Sir.
RNFL, OCT RNFL. So there is a graph, inferior graph. So
here, sir, this is not that clear, sir. Kansky is actually this picture is better than Kansky. Actually, they copied from Kansky.
see,
So I took
are
it
you
from
people
there.
seeing that? Whatever I am doing,
Sir.
image.
Sir, this one, sir, RNFL reading, they are writing like RNFL. This
yeah,
thing.
and can you see anything if I am writing here?
No, sir. Sir, I can see.
You can read. You can see.
Ah.
So the part I am highlighting this part, inferior
Yes, sir.
RNFL graph. So that should be in a double hump pattern. So the green, yellow, and red is the normal age-related graph. So
sir.
dark line is our patient's graph.
Sir.
So that dark line should be follow that double hump pattern.
Okay, sir.
If it is normal. Okay.
Ah.
If it is beyond the green line and it is fluctuating like here, whatever we can see like a ECG.
Okay,
So
sir.
most probably it is not a good quality OCT. Okay. And if you see here in the right upper part of this thing, that which eye it is? Right eye, right?
The right eye, sir.
So that also you have fluctuations, lot of. So if you have a gross thinning of neuroretinal rim also, RNFL also, it will have some flat line or it will follow some double hump pattern in a red zone. Sir. Here in the red zone. But it is more of a fluttering kind of thing. Sir. So this also this also should be looked for. Sir. So it should follow a double hump pattern. Sir. So superior and inferior, whatever we have discussed, no, superior pole and inferior pole is very much thicker. The RNFL also superior and inferior is thicker. Sir. So that we are having double hump there. Sure. One hump is here and one other hump is here. So these humps should be followed.
Sir, one doubt, sir. In central portion, this this kind of thing, sir, but it's not following anything like here.
Yes, so that's what I am telling. That is, it is fluttering actually. It is fluttering like a ECG. It should not be like that.
So in this, they are telling that this left eye is normal, but this also showing this kind of.
Yes.
Okay, sir. Thank you, sir.
Continue.
This sir every slide is.
நான் erase பண்றேன். Erase, no?
Yes, sir. Good. And the sectoral RNFL parameters may increase the chances of detecting localized RNFL damage in glaucoma. These parameters may suffer from lower reproducibility because the measurements are averaged over relatively small areas. But in contrast, the global average RNFL thickness in the most reproducible parameters, and its calculation involves averaging the measurements over a relatively large areas, and they have improved reproducibility, and they help to predict the progression over time. In general, with OCT, the border of the optic disc is defined by the termination of Brooks membrane or its opening. So the Brooks membrane opening minimum rim width, that is BMO MRW, is a parameter for measuring the neuroretinal rim thickness at the optic disc border with the SBOCT. The BMO MRW is defined as the minimum distance from the termination of Brooks membrane to the inner aspect of the neuroretinal rim, averaged over around the disc. Studies suggest that the BMO MRW may be more sensitive than other rim-based parameters for diagnosing glaucoma. Here, an example of SDOCT printed with the calculation of BMO MRW measurement. And this we scan on the right show the BMO MRW measurements, how they are obtained is correspond to the minimum distance section from the border of the Brooks membrane to the internal limiting membrane. The arrows, this arrow shows, and the globe and sectoral.
These are the BMOs.
Sir.
So that green arrows.
Sir, this OCT, sir. This
That
OCT.
is okay.
Okay.
This is the dark line which is showing like this. Yeah.
Okay, sir. And macular region for evaluation of glaucomatous damage. Much of the total macular thickness consisting of retinal nerve fiber layer and ganglion cell bodies in this macular region, and this region is an attractive area for identifying structural glaucoma damage. The macular retinal ganglion cell layer contains more than 50% of the retinal ganglion cells of the entire retina. So investigations have also been suggested that, contrary to the previous belief, glaucomatous damage frequently affect the macular region even early in the disease process, leading to central visual field loss that can go undetected with the conventional perimetry. The SDOCT enables quantitative assessment of either the entire macular thickness or the thickness of the specific layers. The retinal layers that are included in the macular thickness measurements for glaucoma evaluation vary with the different OCT platforms. The thickness of the ganglion cell layer combined with the inner flexiform layer, GCIPL, is the most commonly used parameter for the measurement of macular thickness, and they include the ganglion cell complex, which is composed of RNFL is there, the ganglion cell layer is there, and the inner plexiform layer is also there. So next, imaging of the lamina cribrosa. The lamina cribrosa is challenging to image because of its location deep within the optic nerve head. However, advances in OCT, including enhanced depth imaging OCT, that's EDI OCT, and swept source OCT, SSOCT, have provided the means of imaging deeper ocular structures, including the lamina cribrosa. In EDI OCT, the OCT source is placed closer to the eye than the typical practice. Here, the imager shows the EDI OCT and SSOCT of the right eye of glaucoma patient with a critically visible lamina cribrosa defect. Here we can see the striations and vessel deformity, thinning, everything. And these are corresponding image, enhanced depth, the OCT image of the lamina cribrosa, and this one is swept source OCT image. Another technology used to evaluate lamina cribrosa is adaptive optics. This system uses a wavefront sensor to measure ocular aberrations, for example, those induced by the lens and cornea. A deformable mirror or a spatial light modulator is then used to compensate for measured aberrations and improve image quality. Adaptive optics can correct ocular aberration in real time. Its use can be combined with the use of OCT or scanning laser ophthalmoscopy. Imaging has enabled the identification of generalized and localized configuration changes in laminar cribras of glaucomatous, including posterior laminar displacement, altered laminar thickness, and focal laminar defects that have spatial association with conventional structural and functional loss. Next, optical coherence tomography, angiography. The potential role of the microvasculature and the blood flow in the pathophysiology of glaucoma has been extensively investigated, and studies have shown that the reduced ocular blood flow in the optic nerve head, retina, choroid, and retrobulbar circulations in eye with glaucoma. These changes may simply be a consequence of glaucomatous damage to the retinal ganglion cell and may have no predictive value. The lack of reproducible and the relevant in vivo quantitative assessment method has limited the study of both ocular perfusion and microvascular network as a predictors for future vision loss. Then OCT angiography is a new imaging modality that can be used to characterize vasculature in various retinal layers. Like they can provide a quantitative assessment of microcirculation in nerve head, peripapillary region, and macula. And the principle of imaging OCTA is to contrast blood vessels from static tissue by assessing the change in OCT signal caused by the flowing of blood cells. And the OCTA comprises differences in the backscattered OCT signal intensity or amplitude between sequential OCT B scans. They are taken precisely the same cross-section in order to construct a map of blood flow. The different OCTA parameters include vessel density, which corresponding to the percentage of detected vessel area over a imaged area. Flow index corresponding to a dimensionless parameter between 0 and 1 representing the average signal. And studies have shown that significant difference in vessel density and flow index in the peripapillary and macular regions in eyes with glaucoma patient versus healthy. So these indices have shown significant association with the measures of visual field loss. And this OCT scans of healthy. First, this one is healthy eye. This is mild glaucoma. This moderate glaucoma and severe glaucoma. And here in healthy eye, we can see the scan show dense peripapillary vessels network in healthy eye, and this indicates red and yellow in color code map. And from mild to severe glaucoma, we can see decrease the vessel. We can see vessel damage is there, and this red and yellow is decreasing and is replaced with the blue color, indicating either absence of vessels or no flow, and corresponding visual field loss also we can see. Next summary points. The glaucomatous damage tend to preferentially affect the inferior and superior parts of the optic disc, especially in early stage disease. And fundoscopic determination of the cup disc ratio is an insufficient and generally inaccurate way of documenting the amount of optic nerve damage in glaucoma. It's preferable to obtain objective documentation of the appearance of the optic disc by photograph or imaging. Then OCT is the most commonly used imaging technique. It provides quantity measurements of the peripapillary retinal nerve fiber layer thickness, optic nerve head topography, and macular thickness. So we can discriminate glaucomatous eye from normal eye. Then glaucomatous damages frequently affect the macular region, leading to central visual field loss that can go undetected with the conventional perimetry. This damage may be detectable by OCT imaging of the macula. It's important to consider the possible effects of aging on longitudinal changes of OCT parameters over time. That's all. Thank you.
Keep the previous slide.
Sure.
So whenever you are documenting, like you have to write case sheets also, no case presentations. You have to mention clinical examination of the disc. Very important.
Sure.
Okay, there will be some 7 to 8 parameters by which you have to write.
Sir,
So you have to mention about the shape of the disc. Tell me.
Sir.
You are telling something? Or?
No, sir. I have 7 to 8 parameters regarding this site. So yeah.
That shape of the disc.
Sir.
And you need not to mention size. It is the shape of the disc which is important. Sir. And the shape of the cup.
Sir.
Vertical cup disc ratio.
Vertical.
Neuroretinal rim. What is the color of the neuroretinal rim? It is pink or pale? Yellow, huh? Pale rim or pink healthy rim? Neuroretinal rim. And there is there any focal loss? Focal rim thinning or focal rim loss? You have to mention. Then you have to mention about the vessels over the disc, ONH. Vessels of over ONH, like we have seen bionetting or any bearing or any nasalization or shifting of vessels. So these vessels you have to mention.
Sir.
Then it is a peripapillary nerve fiber layer. Is there any defect or not? It is a healthy. And you have to mention PPA, peripapillary atrophy. If it is there, alpha or beta.
Sir.
And over disc is there any splinter hemorrhages? So these are all should be disc margins. What first whenever you have right shape of the disc, you just mention about disc margin. Disc margins are intact or blurred or however it is. So these should be written when you have writing a case sheet. Right?
Sure. Sure.
Then
Please continue.
Sir. And then the documentation, like it is very subjective. If you see more and more cases, you will be like if you have your own cup disc ratios. But as you mentioned, the cup disc ratio is not important. If it is 0.6, 0.7 also, the cup disc ratio is not important. The
Sir, if we are seeing patients in OPD after fundus like 90D, after seeing through 90D, we are writing nowadays. We are writing CDR like that, sir. Then what should we write in normally in clinic, like
No, in clinics that is okay. Whatever I am telling you have to write whenever you are writing case presentations. No.
Sir, okay, sir.
In case presentations, you have to mention all these findings. And in clinics, you have to write CDR, vertical CDR, and you have to write the rim. How the rim is.
Sir.
So you have mentioned a lot of findings about the rim now.
Sir.
So is there focal thinning or focal loss, notch? So that you have to mention. How is the inferior and superior rims, especially these two poles?
Sir.
You have to look for in clinics.
Sir.
Also, there are early signs.
Yes, sir. Early signs. And if you first you see about you concentrate over the disc, then you will go to peripapillary.
Sir.
Is there any RNFL defect or it is a pinkish RNFL what we are seeing in normal people? So first you see normal people also like a glaucomatous eye. If at all there is a pointry cupping with a healthy rims also, you just see the peripapillary. You just focus on the peripapillary nerve fiber layer, how it will look in the normal eyes. Then if you see the glaucomatous eye with RNFL defect, you will definitely get that, which is a abnormal thing. When you see the normal things, you know which is abnormal, right?
Sure.
So if you are following the dilated fundus examinations, you just look for all these things.
Sure.
Then it will be a normal in normal individuals.
Sure.
If at all any finding is suspicious, you just go to consultant and ask what is this.
Sir.
Right?
Sir.
And OCT also, I just want to highlight OCT, whatever you mentioned, SD OCT of ONH, RNFL, and GCC.
Sir.
Just focus on this thing whenever you have time.
Sir.
Just focus on these three things. Not like OCTA. OCTA is also important, but it is not widely used and accepted for glaucoma. And you have mentioned CSLO. That and all is not doing right now. So the OCT, it should be like after completing your PG, you should read the OCT. You should read the OCT report. Not only just by seeing the color coding, whether it is in the you have mentioned about the sectoral thing, no?
Sir.
That if it is red or whether it is green, you should not directly go to the green or red.
Sir.
You should focus on lot of points in the OCT report. Whether it is a good quality report, the image, is there any mobility, like movement of the eye when we are taking the image? So lot of things are there in OCT report.
Sir.
Whenever you have time, you just try to read OCT, ONH, RNFL, and GCC.
Sir.
Right? So I thought you will be more focusing on this part. You have to focus, but
Sir.
it is a generalized topic. You didn't keep an OCT report properly. So there are zones. How you will see in the visual field report, there are zones which have to look for in the OCT, not directly going to the color coding of the sectoral map. So you have mentioned 4 clock hours, superior, inferior, nasal. Directly you should not go to there. You have to see from the top whether it is a good quality index. There will be an infrared image. The infrared image is properly taken or not. The movement of the eye can be picked up by the blood vessel kinking of blood vessels over there. So that and all you have to look for. And I have mentioned RNFL should be following a double hump. So these and all should be looked for before going for the color coding. Sometimes if it all properly not taken also, the red may be seen. That is false positive. So OCT report you should look for false positives and false negatives also. So if you directly go for a color coding, it might be a red or green. We don't know. And it should be correlated with the clinical findings. So if you are seeing the inferior RNFL thinning, you should see inferior sector which is thinned out. That should be there. That clinical correlation should be there. So these imaging modalities in glaucomas should be supported by clinical evidence, but not directly by OCT or anything. It should be clinically correlated. Yeah.
I think, Krishna, once we do visual fields topic also,
Sir.
any correlation of visual fields, OCT and imaging, under photograph, I think that will give a more comprehensive understanding.
Yes, sir. But I am focusing on OCT because they should know how to read, because it's like a OCT, whatever she told. But I thought it will be more extensive on OCT. It will be better for them. They should know what are all the imaging modalities are there.
Yes.
But clinically, how much it is important is like OCT, what I have mentioned previously. So if at all they have any time, they should enlighten these things.
I think after visual fields, you can just visual fields and OCT correlation. We will have one more class.
Yes, sir. Yes.
Part will stress
Maybe at the time of case presentations also we can have a discussion on this, sir. Okay. Because practically only in practicals only they will have faced these things.
Yeah.
So once we get done the theoretical topics, when we go for a case presentations, we'll be stressing on these things. Because that particular case we can explain them, exemplify them.
So when you are coming on Wednesday,
Yes,
allot them the cases 1 week to Silpa, 1 week to Surya, and ask them to present.
Yes.
Present and do all investigations themselves.
Okay, sir. That is good.
After coming in the morning,
Yes, sir.
Present, give them a case and work up and bring it to you.
Yes, sir. Yes.
Okay.
Sure, sir. Okay, Shilpa. The DDLS, you just concentrate on that.
Sir.
Okay. Yeah, good presentation. Clinically, you have elaborated a lot of things and you have to apply in clinics.
Sir.
Okay.
Thank you, sir.
Good.
Yeah, good. You get a good teacher.
Thank you, sir.
Thank you, sir. You are concluding, sir?
Sure.
Yes, sir.